Good evening, everyone. Recognizing mental health concerns in the elderly. This is our special session today. The event is a part of our ongoing monthly series on community-oriented mental health awareness, proudly presented by VIMHANS in collaboration with the Mind Diaries. Today, we delve into the unique challenges faced by our elderly population and how we, as a community, can better recognize and support their mental health. We are privileged to have with us Dr. Prem Chawla, a distinguished psychiatrist who has made significant contributions to the field of mental health in India. Dr. Chawla is currently a consultant at VIMHANS, Delhi, and has served as an assistant professor in the Department of Psychiatry at AIIMS, New Delhi, from 1974 to 1984. Her academic journey began with an MBBS in 1966, followed by an MD in 1970, and MAMS in 1973. Dr. Chawla has been recognized for her pioneering work in psychiatry, including receiving the prestigious Venkabro Award for Young Scientist in 1984. Since joining VIMHANS in 1995, she has seen the full spectrum of psychiatric services from drug addiction treatment to addressing unique mental health needs of the elderly. As we begin today's session, I request all of you to please keep your phones on silent mode. We also request you to have your questions ready at the end of the session. Thank you so much, Dr. Chawla. We are honored to have you with us. Thank you.
Thank you, Prachi, for such a nice introduction. But if someone asks me about me, आप कौन हैं? तो my answer is कोई खास नहीं. So okay, this just adding on years I passed so long ago, and now also I'm sitting here and talking. That's just luck and chance. So today we are going to talk about problems of the elderly. So most of the talks, they start with charts, graphs about how many millions elderly are going to be there now and in future, and how many problems. So I'm not going to bore you with all that, because that data is essential for the governments who have to plan for the elderly. We here are going to talk about at the individual level and at the level of family. So when we talk of percentages of illness, it makes no difference to the individual or to the family, because for them, if it happens, it is 100%. So we are going to come right to the concept of when the old age starts. Again, for the purpose of administration, planning, retirement, there is a fixed age, 60. And yesterday only we had another age fixed, 70, if you are aware. For government is ready to provide health insurance to each and every Indian who is above the age of 70, irrespective of the income. So these figures are more for administration, planning, and providing some aids to the people who are now retired and need some economic help, like banking services, railways, airlines, etc. So the question is, does the old age start at 60? Like, is there a push button 60 when you are old? Like yesterday, now the Olympics begin. Does the old age really begin at 60? No, biologically speaking, no. We all age at different speeds and at different times in our life. And it can start even before 60, but then we have the magic bullet like 60, and then we are recognized as senior citizens. After that also some people remain young, fairly long in their lives, and this depends upon the energy level and the ability to enjoy life and a positive attitude in the life, that how long we can postpone the old age. And I must say here that women do better than men in postponing the old age, and we will come to the reasons for that also. Now, how we postpone old age and how we remain happy, these points I'm going to discuss over the top, so not here right now, because our emphasis on pathological age, problems of the aging, not the normal age. But I just just want to say that I know 90 plus people amongst my relatives and friends who are very agile in spite of physical limitations and have been enjoying life because of their attitude which says, never say never. So that's the important point in life. Now, when do we say the persons are becoming old, like there is? How indicators, you can say indicators, how do we recognize? So there are physical features, changes in the physical features, the wrinkles, sagging of the facial features, thinning of the hair, graying of the hair. These are some little problems, but not very interfering with life. Then there are pains and aches, then there is slowing, there is muscular power, little less as compared to others, your grip becomes less strong. Again, these are the disabilities which in a way do not interfere in life so long as nobody makes an issue out of them. So these very problems can become issues if somebody becomes very concerned and creates anxiety. But in normal aging, this happens and it is part of life. The problems like visual decline, hearing decline, they can always be tackled with the modern gadgets. So it's not much of a problem. So we can say so long as a person with limitations can enjoy life, have fun, go about the usual responsibilities, have love music, dance, reading books, or appreciate good things of life, that person is not old. So that's the most important. The appreciation of good things in life and the feeling of joy. And added to that, feeling of happiness while participating in the happiness of others. That's very important. These are the things which keep old age at bay. Then, now this is about normal aging. That normal aging, people lose certain abilities, but they're not disabled. And whatever limitations are there, they are still able to enjoy life and also fulfill their responsibilities. The problems comes when there is a sudden change in this behavior. That is a matter of concern. So the matter of concern starts when there is a sudden change, because everyone notices changes as the decades go by and years are added, but then life continues. But when there is a sudden change in the usual normal routine of a person at any age, especially older age group, that the family should pay attention. And I must say here that the changes which occur, which I am going to enumerate, which are a cause of concern, also happen very slowly over a period of time. Sometimes by the time the family recognizes these changes, the changes more or less become irreversible. So the family should be very sensitive to this issue and not neglect any little change in the daily routine of the person. Like it can start forgetting in the patchy fashion. This is important. It's not forgetting all the time. Some events are forgotten. Some sentences spoken in certain gatherings are forgotten. Some people are forgotten. And otherwise, there is a good memory. And the family feels that this person has no problem. They're pretending, they're lying. In fact, this can really cause problems. But this should be recognized that to begin with, the memory loss is patchy. Then there are people who start repeating themselves. This might come because of the forgetting only, they had forgotten. They ask the same questions again and again. Then some people, different people experience different things in the beginning. It might start with forgetting, it might start with difficulty in completing tasks, it might start with managing finances, paying bills, or maybe not able to complete very simple tasks like cooking, even washing hands, dressing. So the family, the caretakers should be sensitive to all aspects of the behaviors of the patient to detect the changes right in the beginning. Here it's a very important point is driving. Now old people have difficulty, definitely difficulty in driving, and because of the coordination difficulties, and the reflexes are not so fast. But because of their stubbornness, it's very difficult to tell them not to drive. So family has to take action. Here I would say the government should also take action. In our country, the driving license, you can get renewed at any age. Even I have a driving license. So sometimes I feel like writing the RTU, they should put a age limit over there. So these are some of the problems which are the telltale signs that now something wrong might happen. This is not normal aging, this pathological aging. And here I must put in a word for normal aging, that there is something called ageism these days, like racism. So ageism is not to be practiced. A person who is normally growing old is aging, is capable of doing everything, and they should not be ostracized. That's very important. So now we come to the pathological aging, that what happens when there are problems. In fact, there are problems like loneliness, anxiety, depression, dementias, so many. And my young colleagues, some of them are not here, Seema especially, they wanted me to talk about loneliness. And loneliness, when she was asking me to talk about loneliness, I always felt that in her young mind, loneliness is some poetic concept, like tu or main or meri tanhai, like that. So I gave a thought to it. Then I found that this, in real life, it's not like this. Loneliness happens in old age in a very pathological way, very, very serious problem. It can even lead to suicide. But who are the loners? So some people are born introverts, and they are happy in their introversion. They are adjusted in their introversion. They are creative, and they don't need people for their self needs. So when these people grow old, then they remain the same. So nobody changes with aging. In old age, we are just a reflection of what we have been always. So these people who were introverts to begin with, they remain introverts in the old age also. They are not maladjusted, and they are not problematic in any way. Problems happen even during youth, and same thing carried over to the old age, when the person is shy and withdrawing. That person is not introvert. This person is shy and withdrawing, as in not happy with her or his shyness, and want to approach people, wants to have friends, wants to do everything, but because of the shyness, whatever the complex is, whatever happened in childhood, but that is how the person is. This sometimes gets carried on to the old age. And such an old person will be very unhappy and lead to problems. Then another special group in old age where the loneliness is a problem is the single senior citizen. Single retired male, maximum prone to this type of loneliness and needs more support. Women fare better here. They feel less lonely because women during their youth, they master the art of living for others, investing into others emotionally, and they remain busy also during their old age. They never retire. There are always household duties. They can always be useful around the household. So they fare better as compared to men because of their attitudes carried to the old age. And here the self-employed people are also better off as compared to the retired single males. So the prevention here for this disorder is that everyone should not just focus on career, money making, but also invest in relationships, like value relationships, cultivate relationships, and invest emotions in others also. And because in the old age, nobody is going to come over and meet you and spend time with you because you were so and so in life. Only those people will come over and spend time with you who have spent happy times with you, or people whom you have gone out to the way or helped them in some way, that cultivated relationships. So this, right at this stage, it's not a medical problem. We can't treat them. It's a social problem. And the prevention of this starts from early life. So throughout life, the people have to invest in others to prevent loneliness towards the old age. So we will talk more about prevention as we proceed further. So the next point, which everyone knows is a medical problem, these are like anxieties, depressions, dementias, so we'll talk about them now. So we have now going to talk about anxiety first of all. Dementia will take towards the end because there's very, very serious illness. First is anxiety. Now anxiety also presents like two ways in younger people, as a habit, as a trait, and as anxiety disorder. So if a person who has now grown old has been habitually anxious, that person remains anxious even during the old age. So that's nothing new. Because in old age we are nothing new. We are just a reflection of what we are, except when there are diseases of the brain. So anxiety, if it is a trait, it's a habit, it gets carried to the old age also. But this anxiety can worsen in old age, because when the old person starts losing grip on their life, then they find the same things rather frightening. The other thing is that when they were young, they were anxious, but still they had control. The steering wheel was in their hands. Now that the steering wheel is not in their hands, so they feel even more threatened by anxieties which are real or even imagined. Imagine anxieties like somebody has gone out of the house and is not back within 45 stipulated minutes, and the person starts getting anxious. But then some people are anxious about nothing, that something is going to go wrong in the future always. And this worsens. Anxiety disorder as such doesn't have its onset in old age. It's usually the carryover anxieties from the earlier age group. If there is an anxiety disorder onset in old age, like I said, the point where we have to be concerned is the change. A person who's happy, healthy, who could live with little anxieties of the life, suddenly starts becoming very fretful. Then this person needs special attention and needs diagnosis also. Like many times, we as clinicians find that these patients who are now anxious, in spite of the fact they had led a happy, healthy life, the impending dementia is happening. That sometimes the first symptom of dementia might not be cognitive deficit, but the emotional problems like anxiety. This happens because they're losing grip on the life, and that it manifests, for the family it manifests as, so extensive history taking, testing will show that is a simple anxiety disorder, or there is impending dementia as well. Now, these conditions are manageable. That we have good medicines, very small doses of these medicines will help the person to relax and lead a normal life. But some of the medicines are very bad also, they're addicting. So they have to be given very cautiously, and we have to pick and choose medicines which don't cause addiction. The doses have to be titrated. So because that medical treatment is not easy, so very extensive counseling. This is a place where family comes in for support. Personal individual counseling and the family counseling goes a long way in the management of these problems of anxiety. So now we can proceed to the next one, that is sleep. Sleep is another problem complained by the senior citizen. Now sleep disturbance can be very much a part of normal aging. That when there is no deficit, there is no maladjustment, no anxiety, no depression, nothing, still the sleeping hours are less. This is because the need of the body for sleeping becomes less in the elderly. Maybe 6 hours of sleep is good enough. But then it can present as not able to sleep, or interrupted sleep many times, or waking up very early in the morning. And some people get very disturbed by it and they complain and come for discussion. So whenever there is a sleep disturbance, we have to take very extensive history, know about the person, and decide whether it is part of normal aging or there is an underlying disorder. If there is an underlying disorder, we'll have to go and treat that disorder. Then only the sleep disturbance will take care of itself. But if it happens in normal aging, that the person is functional, enjoying, but is not able to sleep, or gets up at 1:30 and is not able to sleep till 3:30 or so, and then falls off to sleep again, and there is daytime napping also. The advice to such a person is not to make an issue of the sleep disturbance. It's a very important thing. They should learn to live with it and not ask for sleeping pills.
most of these people come to some medication to help them sleep throughout the night, because the sleeping pills to this normal aging process, when there is no underlying disease, are addicting, and very soon the dose is going to go up and up and up, and not very healthy for anyone. So my advice usually to these patients, I have plenty of them, that they should structure their day. They should have some activities during the day, keep themselves busy, and also structure their bedtime. And if they wake up at night, they should structure their night also. They can have activities at night. Like if they are awake for 2 hours, they can get up, read, or whatever they like to do, any solitary activity where they are not waking up the whole family, they can indulge in that, because the body doesn't need that much of sleep. That is why they are awake. So here again, the counseling of the person and saying no to their demand for drugs would be the management, because otherwise they'll be addicted. So we usually tell them 6 to 7 hours of sleep is good enough for people who are not indulging in any brain work. 60 plus nothing, and 70 plus any age. So if they want to sleep more, they will have to fatigue themselves. They have to do some brain work, and then they'll be able to sleep. So now, what is anxiety? This point I haven't told him. What is anxiety? Anxiety is feeling of apprehension within yourself, apprehension that something is going to go wrong, something is going to go wrong, something is going on. And because of this also there is then sleeplessness. So anxiety neurotics have sleeplessness, depressives have sleeplessness, because they are so sad they are unable to sleep. But a normal healthy people has no issues. When they are sleepless, they're awake. They're not thinking negative thoughts. Their thought process is neutral, but they're not able to sleep. So that would be the difference between normal aging of sleeplessness and abnormal aging of sleeplessness. So next we come to another disorder called depressions. Now, depression, everyone knows depression, because bipolar mood disorders is a word which now everyone knows. And the bipolar mood disorder starts during 20s. And once it starts, and it's carried out throughout the age. The remissions and relapses keep on happening throughout the age, even advanced decades of life, 70s, 80s, anytime. Same is this, there's a variant of bipolar mood disorder called recurrent depressions. In this particular disorder, the manias do not come, but depressions happen. They also come and go. There is a relapse, there is a remission, there is a relapse, remission. It happens in old age also. So they have to be managed exactly the same way as they have been managed during their youth. The problem here is the bipolar mood disorder or recurrent depressions are become little difficult to manage in old age, because old people are sensitive to medication. They have side effects. So the doses have to be titrated, they have to be changed from time to time. And so along with medication, counseling, family support, individual counseling, they are very important. Now the question is, do the depressions happen in old age also? Can they start in old age also? Yes, depression can start in old age also. One way of start depression in old age is like the same depression which would have occurred in youth, exactly the same way it can happen at any age. In fact, all the diseases, physical, mental, whatever, can happen at any age. Usually we say this is the common age in which these illnesses happen, but at extremes can also they happen. Similarly, depressions without any cause can happen in old age also, and then they will be managed with antidepressants and counseling like the depressions managed in youth. But then the special feature of depressions in old age is when the patients are brought not for depression, but as if they have forgotten everything. They don't know anything, as if they have gone into dementia. They don't pay attention, they don't remember anything, they don't want to do anything, and they just don't want to sleep, eat, look after themselves, and the family feels this is now dementia, and they present it like this. But if we look at them closely, take extensive history, do examination, then we find that all those symptoms are of depression. They are just mimicking the symptoms of depression. And once they are treated for depression, they come out and they are very normal. This is very important point. I would say not so much for the families, because for the family the duty is to take the person to a specialist. This is more important for the specialist to distinguish dementias from pseudo-dementias. Very important. Now another point which again I want to mention is suicide. Suicides can also happen in old age. They happen due to loneliness, and they can happen due to depressions also. It's not that, again we have a common age in which from say, young adults 18 or so to 40, most of these suicides occur in this age group, not even 40, 39, but they can happen at the extremes of old age also. Recent example you all know, you read in the newspapers. So another point here, very important point of depression, especially in old age, is sometimes they present not as pseudo-dementia, but as physical illnesses. Large number of physical disorders. They will complain of large number of complaints relating to the body. And they will undergo large number of wasteful investigations. And a simple question of asking the person, are you sad? आपका मन उदास है? आपका दिल कुछ नहीं करता करने को? Would give the answer and the diagnosis. This point is important from the point of view of the family as well as the treating physicians, both. Treating physicians, most of them come to know that this person is depressed and we are investigating, but sometimes they are not able to convey to the family because family doesn't agree with the doctor. They only know the physical symptoms. They do not know that the mental state disturbances can cause symptoms in the body. All the symptoms of depression and anxiety are in the body. So they argue with the doctors, they quarrel, but then the doctors should be clear in mind that their patient has been now investigated as well to assure the family. Although, in fact, if you take a good history, those investigations were not even required. The person asked, pay attention to the person, the depression comes out. And there is a good treatment for depression. We have really good medicines for depression. They'll take care of depressions. And they're not addicting, they're not very many side effects. Like even if there is a side effect, it's not a toxic effect, not a permanent effect. And along with the medications, of course, the family has to be involved. So counseling, support, both to the family and the patient has to be there. So we have done with disorders which we consider minor because we have some treatment available, some solutions available. Now we come to a problem where we feel helpless, and that is dementia. Now, I was talking about the minimal cognitive deficits when I was talking about the telltale signs of dementia, that the person starts forgetting, the patchy memory, unable to complete the tasks. Like this innocuous kind of forgetting, some people remains right at that level throughout and they don't go into dementia. But some of them can progress into dementia where this forgetfulness for the recent events then extends backwards, that they start forgetting past events also. And the forgetfulness can be of recent events or previous day or maybe 20 minutes before, right now. So as it progresses, the attention span becomes less, concentration becomes less, patient's ability to reason becomes less, and there is even lack of judgment. And as it progresses, there's disorientation. The disorientation means the person cannot recognize people around, cannot recognize places, doesn't have idea about the time, even in terms of years. And with the progress of the recent memory, when it goes into the past, large number of swathes of life, they get sort of washed away from the brain. And the person might go into the childhood mode like and there also the memories are patchy. The person starts believing that the person is a child only, but then also the behavior is such that it is not coherent. It's patchy. That they remember some, and it's all intermixed. They remember when they were 8 or 9. They'll remember when they were 10 and 11. They might remember an event when they were even younger. So it's all muddled up in their mind. So because of this progress of dementia, we have divided into a number of stages. In fact, 7 stages are there. But that's more of an academic interest. For a person to know, because these stages can be intermixed also. The person might not be able to recognize a face or the relatives, but the person can still remember something from the past and remember it coherently. So the family says that कहाँ dementia है, इसको तो सब कुछ याद है, हमें भी बातें भूल गई हैं, but this person remembers. So this is very important for psychoeducation of the family, that when the memory is disintegrating, then it is in the form of patches only. Later everything goes away, that they don't remember anything that go into the early childhood. And so you can understand during this phase they cannot manage their daily care, they cannot manage money, and in the end they can't even feed themselves and take care of themselves. Another important point is when the reasoning, the cognition is deteriorating, emotions remain intact. These persons are not able to recognize relatives, but they are able to emotionally connect with them. Like I've seen a person, the son is sitting right in front of her. Like the son goes and works. So whole day she's asking for the son. Kahan hai, Atul kahan hai, Atul kahan hai, Atul kahan hai. When he comes, he's sitting right in front of her. She doesn't recognize him. But she feels happy when he's sitting around him. And the whole day when he's not there, she's unhappy. And the emotional connect is there. So the corollary of this is, and we have the experience is that emotions do not deteriorate the way intellect deteriorates, and mostly they might go up to the level of 8 or 9 months old child. Like infants have emotions. So when there is a brain is shrinking and everything is happening, getting washed out, they are coming up to the light of childhood, the emotions are still there because emotions were there even when the child was 8, 9 months old. And 8, 9 months old experience joy, smiles. So they can experience joy and smile. And the child at age experience what is called a stranger anxiety. Stranger anxiety is easy to understand. Like a child of 8, 9 months is carried in the lap, and if somebody comes and meets and says hello and come, I'll take you. No, the child says no. So that's stranger anxiety. And it's a normal milestone in the development of the child. That means the intelligence of the child is also developing. The child knows this person is not my people, one of my people. And it's only later they come to understand that some strangers are also harmless, they are our people. So then they start interacting with everyone. So old people also get into this particular emotional state. It's very important from the point of view of caring of the dementia patients. So they are best cared for in their own homes by their loved ones, and whenever they are put into old age homes, they really suffer. Then the real loneliness comes. That the loneliness we were talking, almost a poetic concept, is now the cause of suffering over there. Because they look around, they don't find anybody with whom they were emotionally connected at that time. Then they feel they are destitutes, they are nothing, and they deteriorate further. Now the question is of management and treatment for dementia. Management, treatment, prevention, everything. Now once the memory and intellect starts deteriorating, we still have any medicine. We don't have any medicines because everybody is seeking quick treatment. Give a pill and things should get well. So we don't have that pill which will halt the process or reverse the process. Although some medicines are being claimed that they delay the process, but then these medicines are to be given at a very early stage of the illness to delay the process. How much they delay, still it's a point of dispute. So I won't say that go for medication, because the research is still at the level. But before I talk about this, I have to talk about, from the management point of view, about something little more about dementias. Dementias, as I said, once the brain starts losing intellectual capabilities, there is no pill to reduce it. But some of the dementias are preventable. And these preventable dementias are not Alzheimer's. I'll talk a little more detail. These are the dementias caused by lifelong diabetes, hypertension, alcohol abuse, hypothyroidism. So these metabolic disorders of the body also affect the brain and cause shrinkage and cause dementia. Then the vascular changes in extreme old age, the heart disease, same way like we have heart disease because of the vascular changes in the carotid arteries. Same, the brain arteries are also shrinking and enough blood is not going, so vascular dementias are there. So here we can talk of prevention, like a lifelong management of these disorders delays dementia. And even in Alzheimer's, when a patient suffers from Alzheimer's, even the Alzheimer's patient, that person has these diseases, active management of these diseases will delay dementia or delay the progress of dementia. So the actual prevention of dementia lies in treating the lifestyle diseases during early life. So all prevention begins early in life. It might be loneliness, it might be anxiety or dementias. Now, some of the dementias, as they advance, they have associated symptoms for which we will have to medicate them to control those associated symptoms. Not that we have a treatment for them, but we'll have to symptomatically control those symptoms. Like the aggression. Aggression is one symptom in dementias. They are not able to reason and they are restless, and any little annoyance makes them very aggressive. Then there is the paranoid type of thinking. This is something very common, the paranoid. And this is the cause of quarrels in the family, the fights, the interpersonal relationships, difficulties. Because most of these dementia patients, they become paranoid about the family, that their things are being stolen, their money is being stolen, everything is being taken away from them, and they'll blame the family members also for that. And then usually there are arguments, explanations, blame game. So this would need handling, very gentle handling and explanation to the family that this is happening because of the memory difficulties. And when it is, and it can be managed with medication also, very small dosages of some medication. But medication in old age is tedious. It has to be titrated, looked after, like the family of like the way I do, the family has to be taught the total nursing care. I tell them that no doctor can be there with you and the medicine can have side effects. So it has to be increased, decreased, stopped, but then we can have medication which will control aggression, paranoid type of thinking. Then in dementias, there are depressions, as I said, that, and anxieties, because they present as depression, anxiety, they can also be managed. And there is another symptom which is very troublesome, that is sexual disinhibition. As and when presents and whatever the circumstances are, and depending on who's the target, that the target has also to be protected, and the inhibition, this sexual disinhibition, almost like an aggression, has also to be controlled. Here I must say, this is my favorite sentence, that normal aging, that nobody becomes an ascetic at the age of 60. Like, so the sexual behavior continues in normal aging also, and the same sexual behavior continues in dementia. Now the wisdom is not there, the judgment is not there. that when to express, when not to express, and that leads to sexual disinhibition, and it has to be managed. I've seen a number of my patients where women, female patients were complaining about it, and then we had to manage this problem. And the other way around, I've also seen. The husband said, "Kisko pata nahi kya ho gaya?" She was never like this, always demanding sex like this. So that both ways it can happen. Then sleeplessness is there, which can again be given medicines. And as I said all the time, that medicines have to be medicated. Now we come to the dementia, which everyone equates with Alzheimer's. But when we say dementia, Alzheimer's is the thing which comes in the mind of lay people. Now, Alzheimer's is one type of dementia. The others are due to diabetes, hypertension, hypothyroidism, alcohol. So, cause of Alzheimer's is still not known. Since cause is not known, so one point prevention is not there. Extensive research has been going on Alzheimer's. We know what happens in the brain, that what material gets deposited, how much, where, what's the progress, that it's different in different people. It starts, then it might stop for some time, starts again at a faster rate, stops, then slower rate. Like brain autopsies have been done hundreds and hundreds, and every age, every point we know what is happening in the brain. But why it happens is still not known. So till we know why it happens, we have no single point prevention. But then it has been seen in this research only that Alzheimer's type of dementia happens less often in people who are highly educated, very intelligent, and who continue to pursue their intellectual activities during their later years of life also. Then the other points which help in the prevention of this type of dementia is the active social life, exercise, hobbies, close ties with friends, relatives. Now this actually helps social ties, and this is because when you're talking to someone and listening to someone, you have to formulate an answer immediately to that situation. You have to react to that situation, which means your brain remains active. So this is the prevention only. The social life, in groups, within friends, relatives, intellectual pursuits, hobbies, and then the role of diet will also come in. Diet role is, this might be a mini question, so I'm just bringing it here, because diet is important from the point of control of diabetes, hypertension, etc. As such, Alzheimer's type of dementia, and diet will not play a role. But any excessive fats and all would lead to worsening of the situation. And here is another point of being talked about everywhere is omega-3 fatty acids. So again, the research has shown that the fish eating people have less this dementia than as compared to populations who are not habitual fish eating. But as such, the pill, the artificial, has an effect or not is not been established. So fish eating is healthy, but the extract omega-3 as a pill. So the best prevention is a very healthy, happy social life from the beginning and being carried over to the old age. And another factor is the economic security. Economic security and economic independence, they are also the factors which would help the person to remain a happy social life, which in turn will prevent dementia. Not a direct effect, but the indirect effect. So this is more about the governments, that they have to provide for old age, that this prevents illnesses, pathologies. So enough about dementia. Now we can talk about the caregivers also. Now the caregivers, they have their task cut for them the day they find out that somebody has changed from the daily routine. They have to be very sensitive to that, and then they have to adjust to whatever is the change. Seek consultation, counseling, help from the specialist, and their role keeps varying from time to time as the disease progresses. It can be just an understanding and forgiving attitude, like when the person has patchy memories, and then they shouldn't be blaming anybody and trying to be vindictive. So forgiving attitude to total nursing care, say feeding, keeping the person clean, dry, prevention of bed sores, because the illness is going to progress like this. So the happy, healthy person who is walking about doing everything is going to forget, lose judgment, reasoning, not know who he is, where he is, and what time it is, what place. Even they forget the rooms of their own house, where the bathroom is, where the drawing room is, to a level when they are physically also weak and they're bedridden. So the care would vary from time, and the whole family would need support from the system, emotional support, counseling, and in fact in my practice my rule is that the patient has to be looked after. There is no doubt about it, and the life of others also has to continue. So they have to help each other, so that, like I say, roti bhi to khani hai, you have to earn. So the life has to continue, and also the patient has to be looked after. So who are the people to go to when you are having such a problem? So it starts with the family physician, then there are specialists, psychiatrists, neurologists, then we have mental health workers specially trained into these things like psychiatric social workers, psychiatric nurses. So all mental health professionals are trained to handle dementia, but the first person to approach should always be the physician. And towards the end also, when the person becomes very weak and maybe they come to a stage when they have to be they have to be looked after in an ICU. So the care depends how many symptoms, because see, a person is losing mental faculties and is 70 years old. That person can also have a stroke, can also have heart attack. So depending upon the condition, situation, the specialist will keep changing, and the help has to be taken from all of them. And I must add here that VIMHANS is one hospital where such comprehensive care is available. Thank you.